The broadcast is now starting. All attendees are in listen-only mode.
Welcome to the second of the Children with Diabetes Screenside Chats. I'm Jeff Hitchcock, the founder and president of Children with Diabetes, and our guest today is Dr. Jamie Wood, who will present on sick days and stress days. Before we get started, I just want to let you know that there are a couple of attachments associated with this webinar, 2 PDFs. One is the presentation, which you can download and refer to, and the second is instructions on how to use the GoToWebinar interface. Dr. Wood's presentation includes some polls. You'll see those pop up on your screen, and we really want your feedback on those at the time. You will also have an opportunity to raise questions using the question part of your interface. We'd like to hold those for the end, and we've allotted plenty of time for that. But if it's something urgent, Dr. Wood will address it during the presentation. And with that, I'm going to hand everything over to Jamie. There you go. And I'm going to sign off until later.
All right. Just want to make sure, just double checking that you can see my slides.
Yep, they're all good.
All right. So welcome everybody. I'm sad that I can't see you, but today's lecture is a very timely topic, as I think that just about all of us have COVID, the coronavirus on our minds, and are worried about ourselves or our loved ones getting sick with COVID. And Jeff and I thought that this would be a great topic for today, to review what we're supposed to do with our diabetes when we have sick days or when we are stressed. And then a couple comments about what to do if we have to be in the hospital. Now, this lecture is not going to be about COVID, and this will be after I make a few remarks about it. I'm really not going to talk about it again during the lecture. We're asking that you hold the questions to the end, and maybe we can answer some questions about COVID towards the end if I can. But if there is a question about the content of the lecture, if I'm losing anybody, or if I said something that somebody doesn't understand, please write your question and we'll address it so that we can move on and make sure everybody is with us. I did want to say a couple comments about COVID-19 and the infection, and I'm a pediatrician and I take care of kids and adolescents and young adults. And luckily in pediatrics, we know that children are faring well with COVID infection, and they're not, vast majority are not having serious illness or not requiring hospitalization. And although we don't have great data yet, and we're working hard to gather that data, I'm part of a couple of different research consortiums that are gathering data on COVID infection in people with type 1 diabetes, young people with type 1 diabetes. But what we do know from the European experience and in communication with pediatric endocrinologists who have experienced the infection for longer in Europe, predominantly Italy is who I've been in touch with the most, they have not seen significant respiratory illness with COVID and type 1 diabetes. And so I think we can be reassured that children, adolescents, and young adults with relatively well-controlled type 1 diabetes are not more likely to get infected, and they're likely not more likely to have a serious course of the illness requiring hospitalization. But what we do know is that any sort of illness, a viral illness like COVID, like the flu, can cause some problems with type 1 diabetes. And I have heard from some of my colleagues across the country that they have had some adolescents and young adults admitted to the hospital with COVID, not because of the COVID, not because of a respiratory illness, but because they got ketones and they went into diabetic ketoacidosis with the infection. So with that said, let's jump into the lecture and we'll learn about taking care of diabetes when we're sick. So we're going to talk about the goals of management, what happens when we're sick, Why does it cause problem with blood sugars and ketones? We're going to go through 6 sick day rules that we should follow. We'll talk a little bit about managing low blood sugars during illness. Then we're going to leap and talk about another stressful day, which is the common occurrence of an outpatient surgery. For example, if somebody needs their wisdom teeth out. A couple slides about what to do when we have to be in the hospital, and then we'll finish up with a couple of cases to illustrate the sick day rules. So what are the goals of sick day management? The main thing we want to do is we want to prevent ketone formation, and we're going to talk about what ketones are in a couple of slides. But we want to prevent ketone formation because if they become high enough, it can lead to diabetic ketoacidosis, which is a very serious condition where the ketones are so high that it's made the blood too acidic. We also want to prevent low blood sugars. We want to prevent dehydration. And of course, we want to prevent emergency department visits and hospitalizations. Now, anything that stresses the body can be considered a sick day. So common ones would be a gastroenteritis with vomiting and diarrhea, a febrile illness like the flu, like a COVID-19 infection, an upper respiratory infection. Asthma exacerbations can be tricky, particularly because sometimes they need inhalers and albuterol and steroids. Significant emotional distress can cause high blood sugars, maybe not necessarily ketone and ketoacidosis, but it can definitely be stressful days in terms of blood glucose management. Of course, any trauma, significant pain, surgery, and then a very common scenario is when there's an insulin pump failure that may be not recognized right away that led to ketones and vomiting. So it's important to talk about sick day management because most of the hospitalizations in people who have diabetes are people who have established diabetes, meaning that it's not their diagnosis admission, but they had to be readmitted back to the hospital after being diagnosed for some reason. And when people have looked at different case series and different chart reviews, looking back at admissions to the hospital for ketoacidosis, perhaps as many as 50% of them could have been prevented if there had been improved sick day management, if the rules had been followed. Now, you may have learned about sick day management at your diagnosis, but oftentimes that's a pretty overwhelming time and you're learning lots of new things. And so if you're not practicing sick day management, frequently you're going to forget it. And fortunately, illness is rare enough, and there's often long periods of time in between illnesses that you may sort of lose your sick day skills, and it really does take practice. And then some of the guidelines may at first seem counterintuitive, in that I have many people who don't understand diabetes who say, well, if they're not eating, they don't need insulin. But we'll talk about that. And of course, even if you're not eating, you still need insulin. But sometimes the intuition leads you astray. So what happens when we're sick? So when we're sick, the body releases a whole bunch of different kinds of stress hormones. The main one is adrenaline, epinephrine, and there's also norepinephrine and glucagon and cortisol and growth hormone. All of these hormones are released when our body is stressed, and this is the fight or flight response. If a bear is chasing you and your body is stressed, it needs a rapid source of energy so it can outrun that bear or fight the bear. And all of these hormones work together to increase the energy that the body has available by causing the body to make more sugar and also release stored up sugar from the liver and the muscles. And it does this by making the glucose, and it also does it by causing a state of resistance to the insulin so that your body is insulin resistant when you have all of these hormones around. And when your body can't use, and also these same hormones stimulate your body making ketones. So the next figure goes in a picture. So if you have high levels of these hormones. It, one, makes your body resistant to the insulin you are taking, so you need more insulin to do the same job. The hormones also go to the fat tissue and tell the fat tissue to break down and make ketones. And so you may have not known that ketones are a byproduct of when our body uses fat for energy instead of carbohydrate. So the ketones build up and you get ketotic or have ketosis, and then the counter-regulatory hormones make you insulin resistant, as well as make your body make more sugar, and that results in high blood sugars. So I mentioned it before, so what are ketones? So your body makes ketones when it cannot use carbohydrate for energy. And if the carbohydrate is either not there because you're not eating it, or you can't use it because you don't have enough insulin, then it has no choice to use fat instead for energy. And when our bodies use fat instead of carbohydrate for energy, we make ketones. So anybody with or without diabetes will make ketones if they're not eating enough carbohydrate, if they're in what we call starvation mode. Many of you have heard about ketogenic diets or Atkins diets, where people intentionally eat a low carb diet and make ketones, and that's a topic for a different day in people with type 1, but that's called starvation ketones. And then the second scenario is when somebody is not getting enough insulin. So the sugar is there. The sugar is in a way trapped inside the blood vessels and is not able to get into the cells of the body without insulin. And so even though the sugar is very high, it can't get into the cell, and the body, in a sense, doesn't know it's there, and so switches over to fat for energy and makes ketones. There's two ways to measure ketones. There's urine ketones and blood ketones. They are both fine and they both work, but there are some differences between the two. Urine ketone strips are cheaper. They're very readily available at the pharmacy, over the counter, but they measure acetoacetate, which is one form of a ketone. They take longer to turn positive and they take longer to return to normal. So when you're getting sick, your body first makes a ketone called beta hydroxybutyrate. And again, don't remember the terms, it's not going to be a quiz at the end, but the point is that when your body is first making ketones, it makes beta hydroxybutyrate, which is what we measure in blood ketones. And then as our body metabolizes the ketones and starts breaking them down to get rid of them, they turn into acetoacetate. So there's a bit of a delay in urine ketones when they turn positive. And then when you get more carbohydrate, get more insulin, and the ketones start going down, they're changed from beta hydroxybutyrate and metabolized to acetoacetate. And so it can take longer for the urine strips to return to negative. Whereas in the blood ketone strip is measuring beta hydroxybutyrate. And so that's the first ketone that forms, so they'll turn positive faster. And then as the beta hydroxybutyrate goes down after you get some insulin and it is metabolized into acetoacetate, you can see the blood ketone level fall quickly right away, which is reassuring. But blood ketone strips are more expensive, and they're not always covered by insurance. I practice in Ohio, and I have a bear of a time getting blood ketone strips covered for my patients. But they are helpful. A lot of parents of toddlers like to use them because they don't have to try to catch a urine sample. For example, if they're still in diapers, teenagers like them because they might find it embarrassing to go pee on a stick in the bathroom. It's also helpful when somebody might be a little bit dehydrated, going to the bathroom as frequently, and that you can always prick a finger and get a blood ketone. And there have been research studies that compare sick day management with urine ketones and blood ketones. And it has been demonstrated that there are fewer emergency department visits and fewer hospitalizations when individuals are using blood ketone strips when compared to urine ketone strips. So the blood ketone strips give you an actual number. You don't have to decide how dark of a purple the urine ketone strip has turned. It actually gives you a number that you can interpret pretty easily. You want a number below 0.6, below 0.6, and that is considered negative. 0.6 to 1 is considered small. 1 to 1.5 is comparable to moderate, and over 1.6 is considered large. When we get readings above 3, that is the danger zone, and that's when a level above 3 could be consistent with diabetic ketoacidosis. There's a bunch of different meters on the market. Probably the more common one is the Precision Extra, but there are others. Okay, so this is not actually a rule, but before we get into the sick day rules, the first thing to do is to have a sick day cupboard ready. I find that when I'm taking sick day calls from the families that I take care of, it's often that they may not have carbohydrate-containing beverages around because they live with someone with type 1. So having a Tupperware bin somewhere or a shelf in the cupboard where you have some sick day foods available that have carbohydrate in them, it can come in quite handy. So having soda, having some Gatorade or Pedialyte, regular Jell-O, regular popsicles, clear broth soups, crackers, things like that. And then of course, you want your ketone strips. You want to make sure they're always filled so that you don't have to head to the pharmacy when you need them. You have them ready to go at home. Thermometer, and nowadays it's hard to get your hand on a thermometer, but having a thermometer is of course important. You want to have ibuprofen and Tylenol around to control for pain or for fever. And then I also urge my patients to have a portion of Zofran handy so that they have nausea and vomiting. They can give it, and that can often be very helpful, as well as an antidiarrheal medication. However, I educate my families to call the doctor on call, give the Zofran to make sure that it is okay to give and it's the right sort of scenario to give it. But have it at home so that you don't have to head to the pharmacy when you need it. Okay, so into the rules. Rule number 1 is never omit insulin. Most people with diabetes who get sick actually need more insulin on their sick days because of the relative insulin deficiency that we talked about caused by all of those stress hormones, epinephrine, norepinephrine, growth hormone, cortisol. And then we use the presence of ketones and the blood sugar level together to help determine what insulin dose we need. In that if you have a blood sugar of 250 and have ketones or maybe trace ketones, you could take your normal correction dose. But as the ketones become larger, you are going to need more insulin to do the same job. And these are very rough guidelines, and they differ a little bit depending on the scenario. But in general, as the ketones are increased into that small ketone range, I'll have patients increase their correction by 20, 25%. The ketones are getting up to moderate or large. Sometimes I'll have them increase that correction by as much as 50%. So if they normally would take 10 units for a blood sugar of 300, if they have large ketones at the time, I would have them increase it by 50% and give as much as 15 units for that correction. Now, many families and parents or individuals may not feel comfortable making that decision on their own. So if you don't know how much to give or you're not feeling comfortable or have enough experience, please call your friendly diabetes team and ask for their recommendation and guidance on how much extra insulin to give. But the message here is never stop the insulin. I had one of my patients when I was a fellow have surgery, and the well-intentioned but misguided team that was taking care of her decided that because she wasn't eating, she didn't need to wear her pump. the night before her surgery, and unfortunately she went into ketoacidosis without her basal before the surgery, and we had to delay the surgery. But you never omit your insulin, especially the basal insulin. Okay, so rule number 2 is work really hard to prevent dehydration and also low blood sugars. And I know that many people that are listening are not parents of children or are not young people themselves, and you may be an adult living with diabetes. So these volumes here are a little small and would need to be increased for an adult-sized patient. But when we are sick, we really need to encourage hydration, and we want to take frequent small amounts of fluids. I use a rule of 150 for a younger child. Sometimes I'll recommend a rule of 200, which means that if the blood sugar is above 150, or for a younger child 200, they should be drinking sugar-free fluids, water, diet soda, diet Snapple, sugar-free popsicles, Powerade Zero, Crystal Light, really anything that they like and you can get into them. And that will help keep the blood sugar down and hydrate them. But if the blood sugar falls below 150, or in a younger child below 200, you should switch over and start offering sugar-containing fluids, such as Gatorade, Powerade, regular soda, Pedialyte, popsicles, regular Jell-O, so that they're getting that carbohydrate. And remember when we said before that carbohydrate and carbohydrate with insulin is what keeps the ketones away. So even if somebody's blood sugar is normal, but they're not eating, they will make ketones. So you don't have to have a high blood sugar in order to have ketones. And the way to prevent that is to continue to offer carbohydrate in the liquids. So rule number 3 is to monitor frequently. And of course, being on a CGM would be helpful in that you can monitor continuously. If you're not on a CGM, checking your blood sugar every couple of hours so that you know if you're climbing or if you know that you're dropping. Check urine ketones every time they void. If you're checking blood ketones, keep an eye on the ketones every couple of hours, every 2 to 4 hours. When patients are pretty sick, I have them actually keep a sick day log of what are the blood sugars doing, what are the ketones doing, when did they last go to the bathroom, so we can keep track of dehydration. And then if you have to call into your diabetes team, you'll have the records to review with them, because oftentimes when you're sick or your child's sick, remember the days and hours kind of flow together. So it's helpful to keep a logbook and keep track of everything. So back to this rule, this booster dose, we alluded to it before, that we never omit our basal insulin. And then we provide supplemental, what we call booster doses of our rapid acting insulin. And that dose is determined not only by the blood sugar, as we talked about, but also by the ketone level at the time. And then that dose can be repeated every 2 to 3 hours, depending on how long you think insulin lasts in your body or in your child's body. So a teenager or an adult may do a correction or a booster dose every couple of hours. A younger toddler or a younger child, it might be every 3 hours. And again, if the ketones are negative or trace, you can go ahead and give your normal correction according to your scale or your insulin sensitivity factor. But as the ketones start going into the small range, consider giving more, and then even more when they go into the moderate or large range. The other handy way to give more insulin when you're sick and your blood sugars are running higher is to give a temporary basal increase in your pump. And that can also be quite helpful. I usually will start by increasing the basal by 15 to 20% and then going up as needed. And here, we're going to talk about this again later, but if you are on a pump and the ketones are developing, you need to, 1, make sure that your infusion set is working and your insulin is good and your pump is working okay. And if you need a correction and you need a booster dose, you should give it with a shot until you know that your pump is working and you know that you're going back in the right direction. Okay, so number 5 is to treat the underlying triggers. And this is a way to decrease the stress on the body and to make sick days a little bit easier. And so if it's an ear infection, get antibiotics, or if it's a pneumonia, get antibiotics, strep throat, take antibiotics. And of course, you're going to be consulting probably with your primary care doctor as well as your diabetes team to get the proper treatment. But if there's an infection, treating it is important. Fever reduction is really important. One, it's going to make somebody just more comfortable and feel better, but it will also significantly reduce the stress that's on the body. Fever is a healthy adaptive response to an infection, and it's not something to be afraid of, but febrile illnesses are more ketone prone than non-febrile illnesses, so reducing the fever can help with prevention of ketones. Now, I'm asked this question all the time, so I will make one COVID comment here, in that earlier on in the pandemic, there were reports that we should not be using ibuprofen, and that ibuprofen was associated with a more severe disease course. I think the jury is still out on that. So I'm not saying not to give it. What I'm telling my patients is to use Tylenol as a first line. And if that reduces the fever and makes you more comfortable, great. But if it's not and you want to try ibuprofen, I think that's fine. I don't think there's enough evidence to say that we shouldn't be using ibuprofen at all. Pain relievers also, so if there's pain with an ear infection or if there's a broken bone, taking care of pain will significantly reduce the stress on the body. Like I mentioned before, taking antiemetics or anti-nausea medications such as Zofran or also known as ondansetron will help. And one thing that we run into a lot are people who live with diabetes, type 1 diabetes, as well as asthma. And they both are sort of in that autoimmune group of illnesses. So I have a lot of patients with type 1 and asthma, and albuterol can really raise the blood sugar. And so oftentimes with a little trial and error, I'll have families give a small dose of a rapid-acting insulin whenever they give a breathing treatment of albuterol or Zopinex. So start low, a small dose, and then increase, and that can often help with the high blood sugars that come after a breathing treatment. Steroids are also often needed in an asthma exacerbation, and those can markedly increase blood sugars. And I have seen some of my patients with type 1 diabetes who need to double all of their doses when they're on steroids, sometimes even more than that. And so sometimes it's a call to two different teams. You know, oftentimes your diabetes team will be the first call, and we can guide you on what to do with the diabetes and guide you about whether or not you should call your primary care doctor. But oftentimes you also should be calling your primary care doctor to get guidance on treating whatever the underlying illness may be. All right, so rule number 6 is vomiting in someone with type 1 diabetes is presumed to be from acidosis until proven otherwise. And I've seen time and time again, somebody who begins to vomit type 1, and they're like, oh, it's food poisoning, or oh, maybe I had a stomach bug, but it's really vomiting from ketones and ketoacidosis that is the cause, maybe from a pump site that went bad, or another reason. So I like to teach my patients that there's 2 times you check your blood sugar, you check ketones. You check ketones when your blood sugar is high, so 2 numbers over 250 in a row, or any number above 350. And you also check ketones when you're sick, even if your blood sugar is okay. And that's a good rule to follow for this reason. And this is actually a pumpkin that was carved at a diabetes camp by a teenager who is vomiting. Okay, so when should you call for help? And a lot of families with practice start feeling pretty confident with sick day management, and they can get through most scenarios alone. But newly diagnosed families or families that have just had a lot of experience with sick day should call early, not even if these things happen, but should call early on for guidance. We are more than happy to be there to help and talk you through. But when you definitely should call for help is if you've been vomiting for more than a couple of hours. If you have moderate or large ketones and you're not sure what to do with dosing, especially if they stick around and you can't get rid of the ketones or you can't get the blood sugar down. If you feel like you or your child are getting dehydrated, if their mouth is starting to look dry, I look in their mouth for spit. Yeah, do they still have spit inside their mouth, or is the inside of their mouth getting pasty and sticky? Looking for cracked, dry lips, sunken eyes. The eyes just seem deeper, and the eyes, I always talk about how the eyes lose their sparkle when a child's dehydrated, and that they don't sparkle anymore. And they can actually have signs of loss, and they can look gaunt in their face when they're dehydrated. And then, of course, you should call right away if you have any signs of diabetic ketoacidosis, such as nausea, belly pain, vomiting, chest pain, chest tightness, difficulty breathing. If you smell ketones on the breath, and I always tell families that some people have a nose for ketones and some people have a harder time smelling them. I'm one of those people that has a nose for ketones, and I describe it as juicy fruit chewing gum, or nail polish remover mixed with a little bit of overripe fruit. So it's a sweet but not pleasant fruity odor to the breath. Then, of course, if they're lethargic or have altered consciousness, you need to call right away. Okay, a few words about low blood sugars and sick day. Oftentimes, this low blood sugars creep up when it's a gastrointestinal illness with vomiting and diarrhea. And so this is a time when your insulin doses may need to be decreased a little bit. Particularly the rapid-acting insulin may need to be decreased during the illness as the intestines are healing. This is another great time to use your temporary basal rate pump and perhaps lower them by 10 to 25%. You really don't want to lower your basals too much, though, in that you need your basal insulin to keep the ketones away. So a slight reduction can help, and then supplement the blood sugar with sips of carbohydrate-containing liquids. And one of the tricks, especially if it's vomiting or diarrhea, it's hard to know how to cover sips of sugar-containing beverages, and when to give insulin, because you're not sure it's going to stay down. If somebody's throwing up and you're giving them sips and they're throwing up every couple of hours, you're not sure how much insulin to give for those carbs they take in. So if the blood sugar is under 150 or under 200 in a smaller child, I'll have them give small sips of sugar-containing beverages without insulin, but then give a corrective dose of insulin every couple of hours if the blood sugar goes up above 200. And this common sips of carbohydrate-containing liquids and insulin will help prevent those starvation ketones we were talking about. And it's helpful when you're still in that initial phase and you're not sure they're going to be able to count the liquids. Now, this is something that I use all of the time, and I'm getting a little nervous because now a lot of my patients are switching to the intranasal glucagon or the glucagon pens. And so until we have a Minidose glucagon pen, I'm worried that people are no longer going to have the old red kits around to do Minidose which is a great trick to have up your sleeve when you or your child are unable or unwilling to take carbs to treat a low because you're just too darn tired, you're nauseous, and you just can't fathom the idea of drinking some juice or eating some tabs, or you're vomiting and you can't keep it down, or you've treated a low 3 times in a row and you're full and you just can't take any more. So these are the scenarios where I would use what we call Minidose glucagon, and you take your glucagon kit the way it comes from the pharmacy, and you inject the diluent that's in the syringe into the vial here, and you mix it as you would if you were to give it. And instead of using the syringe that comes with the kit, you use a regular insulin syringe. And you can draw a very small dose that can be used to raise the blood sugar. So the rule of thumb is that you give 1 unit on the insulin syringe for every year you are old, up until a maximum dose of 15 units. So the lowest dose is 2. So if it's a 1-year-old, you would give 2, but then a 2-year-old would get 2 units, 3-year-old would get 3 units, all the way up to a 15-year-old would get 15 units, but then a 20-year-old would still get 15. So the maximum dose is 15 units on an insulin syringe. And then you draw it up in the syringe and you give it like you would give an insulin injection. You can give it sub-Q, back of the arm or in the upper outer thigh or the buttocks, anywhere that you would give insulin. And then you can keep that vial mixed in the refrigerator for up to 24 hours. And you can repeat it, and you can repeat it as long as you need to in that 24 hours. If 24 hours goes by, you'll have to mix a new one. So if you use this method, you want to remember to refill your glucagon kit if you're using it for Minidose, so that you have a full kit ready and available if you were to have a severe low. So again, this is not to be used if you're having a severe low, if somebody is passing out or starting to be altered or combative. You would use your full dose glucagon for that. This is when a child or person with diabetes is still alert and able to cooperate with you, but they just don't want to treat again by mouth. Okay, just a couple words about stress days, and this is another common call we get, is how do you manage when you need to have surgery in the outpatient setting? Most common would be, for example, wisdom teeth removal. So the first guideline is that you want to request that the surgeon asks for recommendations from your diabetes team. They should ask for a consult. They should ask for those recommendations in writing. And then the second request is that you or your child be scheduled the first case of the morning. And that's because you're likely not going to be allowed to eat or drink anything the night before. And so having the surgery first thing in the morning will just decrease the amount of time that you have to go without eating, and decrease the opportunities to run into, for example, low blood sugars. You're going to want to ask for the instructions for what we call the NPO order, which is the nothing by mouth order, meaning how long before the surgery are they allowed to drink. So for example, some surgeons may say that you can have clear liquids up to 3 hours before the procedure. And if you have a low, apple juice is clear, so you can treat lows up to 3 hours before the procedure with apple juice, for example. But sometimes they want nothing by mouth at all up to 8 hours before. So you need to understand what those instructions are. And the next, you're going to want to call your diabetes team over the phone, or perhaps schedule an office visit if there's time to plan, to review the operative plan or the management plan well in advance. If a person with diabetes or a child with diabetes needs to be NPO overnight, and they're well controlled, tightly controlled, and they often will wake up with blood sugars in the 80s, 90s, we may reduce the basal insulin the night before to reduce, again, the chances of having a hypoglycemic event that would require food while you're waiting the surgery. You're going to check the blood sugar frequently overnight and upon awakening. And what I have people do is to give extra insulin if the blood sugars are high. And then the morning when they wake up, check the blood sugar and give a corrective dose of insulin if the blood sugar is above 200. And then they can repeat that every couple of hours before the surgery and then also after the surgery. The anesthesiologist should also be checking the blood sugar, and this is part of the orders that your diabetes team will put together. And if they're not on a CGM, I'll ask the anesthesiologist or whoever is monitoring the patient to check the blood sugar every 1 to 2 hours to detect low blood sugar and also high blood sugar. Going under anesthesia is a mild stress to the body and will elicit those same hormones. And so it is much more common that we run into higher blood sugars than lower blood sugars. If you're on a pump and your blood sugars are running low or high, you can use your temporary basal to either lower the insulin or increase the insulin. And of course, if you're on a continuous glucose monitor, talk to the surgeon and anesthesiologist about that, because I've had many be willing to watch the CGM during the surgery. And oftentimes they may not be aware of them or familiar with them, but with a quick overview, they're often very willing to keep an eye on the CGM during the surgery. Okay, so once you're through the procedure, you want to make sure that you're able to keep down fluids before you go home. You don't have to eat a cheeseburger before you go home, but you need to at least be able to keep fluids down so that you can stay hydrated as well as drink your carbs to keep those starvation ketones away. And this is another example for when that sick day cupboard comes in handy. Having Sprite or ginger ale around or broth, popsicles, sherbet, things like that. You want to make sure you stay right on top of pain. So take pain medication schedule. Don't wait for the pain to return to a high level before you take more. Aggressively control that. Keep an eye on your blood sugar every 2 hours or wear a CGM. Check ketones periodically. And again, you don't need to wait. You shouldn't wait until the blood sugars are high to check the ketones. If you're not eating normally or you're sick or stressed, even if the blood sugar is looking decent, you should check your ketones periodically. And this is a time where you want to make sure you have your glucagon handy, in that if you're still recovering and not eating fully or still might be nauseous from the anesthesia, you'd want to have mini glucagon or regular glucagon available to treat a low. And again, I just repeated the same slide on the Minidose glucagon. So 1 unit for every year of age up to a maximum dose of 15. My rule of thumb is that if you're using Minidose glucagon and you need to repeat it, that you should be calling your diabetes team for further advice. This isn't in the glucagon works by going to the liver and telling the liver to release stored up sugar. And if you need to repeat this and you use it a couple of times in a row, the sugar in the liver will be depleted and it will stop working. So you need to, as soon as you can, you need to also treat, be able to take in carbs to fill up those stores again. So if you're needing to use it and you've used it twice, think about calling the diabetes team and touching base to make sure that you're still doing okay. The other scenario where glucagon does not work well is if somebody is low from alcohol intake. If you're intoxicated and have alcohol poisoning and you're hypoglycemic because of that, glucagon is not going to work effectively in that scenario. That's a different kind of sick day, but it is a sick day nonetheless. Okay, hospital stays. Hospital stays with type 1 diabetes can be very challenging and stressful. They can be related to the diabetes or they can be unrelated to diabetes. If possible, try to have yourself or your child admitted to the hospital where your diabetes team works. If not possible, have the doctors taking care of you call and consult with your diabetes team that know you the best. It is okay to ask for a transfer. I was on call last weekend and I had 2 different teenagers in diabetic ketoacidosis, and they went to outside emergency rooms because they were the closest, and both asked for a transfer to be with us. It's okay to ask for a transfer to go to the hospital where your diabetes team works. I want especially the parents out there, but also the young adults or adults living with type 1, I want you to consider yourself the expert in diabetes and in type 1 diabetes management. And if something doesn't seem right, it's probably not right. And ask questions and advocate politely, but advocate for yourself and your child. Oftentimes, well-intentioned nurses and well-intentioned doctors who don't take care of people with diabetes are unfamiliar with pumps, unfamiliar with CGMs, and honestly just don't know. And they may make a recommendation that doesn't seem right, like, you don't need to wear your pump if you're not eating. And so if something doesn't seem right, ask and advocate for yourself or your child. Again, another reminder that if you're unable to eat, you're either not allowed to eat or you're too nauseous, remember that your basal insulin still needs to be continued. And they should be checking your blood sugar or relying on your CGM every couple of hours with high blood sugar corrections as necessary. Now, hospital, there are different policies for the use of insulin pumps and CGM, and also the hybrid systems like Basal IQ or Control IQ or the Medtronic 670G, that many hospitals will allow you to stay on your pump and your CGM, but you need to self-manage in collaboration with the staff. And that's because hospitals, it's hard to keep nurses and doctors unfamiliar with diabetes up to speed on all the technology. So we, at least at my hospital and many hospitals that I worked at, have a policy that the parent or the person with diabetes can manage their own pump, but you need to talk to your nursing staff, let them know what you're doing, tell them when you're how much you're eating, what you're bolusing, if you're changing your basals, when you're changed your site, when you need to change it again, so that you can be in communication together. Now, make sure to know that you can use your own set device if you're checking blood sugars on your fingers, because they're far less painful than the single-use Lancets that the hospitals have to use. Just a warning that most hospitals will not allow you to use your home blood sugar meter. They'll require that you use a hospital meter. It depends on the hospital, what brand it is, but they will not likely let you use your home meter. Most hospitals are starting to become more comfortable with sensors and will allow people with diabetes to wear their sensor during the hospitalization, but they may also require you to check your blood sugar on your finger a couple of times a day. And that's because continuous glucose monitors are not FDA approved for in-hospital use. They're approved for outpatient use, and there's scenarios in the hospital where the sensor may not be accurate. For example, if you're dehydrated or you're anemic, meaning your blood cell count is low, or your oxygen level is low, those are variables that will make your sensor not as accurate. And so many hospitals, most hospitals, will require you to check your blood sugar in addition to using the sensor. And I think that's probably the right thing to do. Other advice in the hospital, carb counts are done by the hospital kitchen and the cafeteria, and they may not be accurate. I've seen some portions of mashed potatoes come up from a cafeteria that were not 15 grams. So it can be highly variable, and you can look at it and see what you think, but feel free to speak up if you say there is no way that dinner is 45 grams, that's closer to 65 grams. So you can do your own carb counts in the hospital and just speak up. You're going to need to bring all of your own pump and sensor supplies. Hospital will not have infusion sense or CGM supplies. Most hospitals won't even allow insulin pens in the hospital. They won't use a device that could be used mistakenly on more than one person. So they will use a vial and syringe. And most hospitals will only have certain brands on their formulary. They may only use Lilly products or may only use Novo Nordisk products. And that's okay. You can, if you're comfortable, you can interchange, and vast majority of the time that's not a problem. But you can also bring in your home supply and use that. And then I think most importantly, obviously the first priority is your getting better and taking care of the illness, but also take the opportunity to teach and to educate and to raise awareness of type 1. Teach that nurse what a pump is, teach that doctor not to take it off when you can't eat or drink. Take that opportunity to raise awareness of living with type 1. Okay, let's do a quick time check. So now we are going to do a couple of cases. So Olivia is a 3-year-old. She has had type 1 for a year. She's on Lantus and Humalog injections. She woke up, she's had a fever for a couple of days, up to 102, but then she woke up vomiting, and she's had 1 episode of diarrhea. She's a little pale, but quiet. She's alert. She's breathing normally. Her mouth is still moist. She's got lots of spit in her mouth. Her skin is still feels good, and her eyes don't look sunken, and they're still sparkly. And she's gone pee twice in the last 6 hours. So she's sounding pretty well hydrated. But you check the blood sugar, it's 305, and you realize you follow your sick day rules, and you check ketones, and they're large. So what should Olivia's parents do or not do? So this is going to bring us to our first audience poll, and this is the first time that I have done this, so bear with us if this does not work.
Okay.
Jeff has opened the poll.
Yep.
And so the question is, which one of the following should her parents not do? So we want to pick the choice that they should not do. So should they not check blood sugar and ketones? Should they not determine the insulin dose based on BG and ketone level? Should they not check the blood sugar and give an insulin dose according to their scale? Should they not try to reduce the fever with Tylenol or ibuprofen? And should they not offer sips of sugar-free fluids with a blood sugar of 305? So which one of these should they not do?
We've got a few more seconds to vote. All right. We still have a couple people voting. Let's see. We're going to stop the voting and report the results. All right. Jamie, can you see the poll results? 72% who say they should not check blood glucose and give insulin according to home scale. 7%.
Great, so those 70% are right. So the correct answer here is C. And this is the one that you should not do. And so this goes back to one of the first rules, that when you're sick and there are ketones, that correction dose is determined by the blood sugar and the ketone level. So if you check the blood sugar and give insulin for just the blood sugar, then that's likely not going to be enough insulin, and that you want to give a booster dose at the same time with that correction. And with large ketones, I might give in a sick sounding child, I might give 50% more. So if this little girl was going to get 2 units for a blood sugar of 305, I might recommend that they give 3. But we do want them to offer a fever reducer. We want them to offer sips of sugar-free fluids to keep her hydrated. All right. So as we keep going, so they offer small, frequent amounts of sugar-free. They give a correction every 2 to 3 hours in a young child, probably closer to every 3. That first correction dose, they went up by 50% for the large ketones. And then I monitored her really frequently, kept an eye on the blood sugar, kept an eye on the ketones. And I also, if they had called me, I would have reviewed with them when I would want them to call back, and they gave her some Tylenol. So 3 hours later, Olivia has a blood sugar of 105, but her ketones are still large. She stopped vomiting, which is good. Her diarrhea is getting a little bit more frequent, and she doesn't want to eat anything. They tried toast, they tried crackers. She does not want to eat. So what should they do now?
Here's the next poll.
So second poll. So the options are A, they should give more insulin for the large ketones. Option B, they should switch to carbohydrate containing fluids and try to get the blood sugar up a little bit. Option C, they should continue carb-free fluids. The blood sugar is 105, that's normal, so we should continue with sugar-free fluids. Or the glucose is in range, so we can stop monitoring her blood sugar.
All right, let it go for just a couple more seconds here. We've got most people have voted already. All right. 71% switch to carbohydrate containing fluids.
Great, and that's the correct answer. So if you give somebody with a blood sugar of 105 more insulin, you might cause a low blood sugar. And without giving carbohydrates in combination with more insulin, you're not going to clear the ketones. You'll just probably cause a low. So the answer here is to switch to sips of fluids that have carbs in them. And then that way you can get the blood sugar up a little bit higher so that you can then you can give more insulin. You wouldn't want to continue carb-free fluids because, again, you need carbs and insulin together to keep the ketones away. And even if your glucose is in range, you're always going to keep monitoring frequently because it could start going the other direction and start going low. So you're going to still monitor. And one other comment here is that I see this a lot, that when you have a high blood sugar and you have ketones and you give that first dose of insulin, when you check ketones the next time, oftentimes they're still high. Sometimes they may even appear higher. And that's because we learned it in the beginning of the lecture. It's because if you're measuring urine ketones, you are measuring acetoacetate, which is the metabolite of beta hydroxybutyrate. So as you clear the ketones and you give insulin and beta hydroxybutyrate starts going down the right direction, you're clearing them, they're changed into acetoacetate. So they actually will look darker at first on the urine strips. So if your blood sugar has come down and you or your child is feeling better, then watchful waiting is appropriate, but sometimes they don't go down at first and sometimes they actually may appear darker. Whereas if you were using blood ketones and you checked blood ketones after an insulin dose, you'd be able to see that decrease in the beta hydroxybutyrate right away, which is reassuring. Okay, so we're going to reassure Olivia's parents that ketones will take a while to clear, but to continue to check them and they should go down. And that we're reassured that her blood sugar came down and she's looking better. We're going to switch to sips of sugar containing liquids. We're going to avoid fruit juices because they make the diarrhea worse. We're going to keep an eye on her blood sugar, keep on assessing her hydration status, especially because the diarrhea is getting worse. And then we're going to give carbs and insulin together to help clear the ketones and prevent more. All right, so the next morning, Olivia is no longer vomiting, but she's still having diarrhea. And now the blood sugars are starting to come down, and she is still unwilling to eat. Her ketones are small, so we're doing well there. And she was taking fluids okay, but now she's refusing to drink, and she's low, and she has a blood sugar of 58. She's looking at you with pursed lips, shaking her head no, and what do you recommend? I do not have an audience poll in this, so I'm imagining that I'm having a resounding Minidose glucagon response out there in the audience, and you would be right. You would give her, in this sort of situation, I would recommend giving a Minidose glucagon. It's the perfect scenario. She's vomiting, she's nauseous, you've treated a couple of lows, she's just not having it. You can give her a Minidose of glucagon in an insulin syringe. She's 3, so we'd give her 3 units on an insulin syringe. And then we would save that vial because it's good for another 24 hours. And this is really, really common when you have a diarrhea illness. And that's because the lining of the intestine has been damaged by the virus and is not absorbing carbohydrate very well. So a lot just kind of runs through you and keeps going, and you don't absorb the carbohydrate as well. So running into lows is really common in that after not so much in the vomiting stage, but in the diarrhea stage of a gastrointestinal illness. If you're running into persistent lows, you may consider decreasing the basal dose or using a temporary basal on the pump. I often find it effective to maybe decrease the basal a little bit, but then give less insulin for the carbs because not all of the carbs are being absorbed. All right, so Jackson, and anyone knows my kids, Olivia and Jackson are the name of my 2 kids. So Jackson is a 16-year-old wrestler, and he has type 1. He's on a pump. His most recent A1C is 8.3, so he's doing well, fairly well. He's just had a wrestling tournament, and his blood sugar at bedtime was a little bit high, but he decided not to correct it because he often will go low overnight after he's had a full day tournament. So he goes to bed, does not take a correction, and he wakes up the next morning nauseous, vomiting, with high blood sugar and large ketones. So he did the first few rules perfectly, right? He woke up, wasn't feeling well, so he checked the blood sugar, realized it was high, and the first thing he did was check his ketones, and they are large. So last audience poll, true or false? It is okay to give a correction dose plus a booster dose through his insulin pump at this time. True or false?
The votes are coming in. We'll let it run a little bit longer. All right. So we have 71% say false.
Good. So they are correct. So if you're on a pump and you have high blood sugar and ketones, the cause of the high blood sugar and ketones is a bad site until proven otherwise. And this is the perfect scenario. He had been wrestling all day. And I'm sure that, and these are actual calls that I got from some of my patients, and I'm sure his infusion set was just tugged just a few too many times and was out, but still stuck to his skin. So if you have ketones, you need to presume that you have an issue with your pump site, or you ran out of insulin, or the battery died, or there's a mechanical failure at the pump, or something happened, and that you're not getting insulin. So when you're in this scenario, and you have a high blood sugar and you have ketones, you want to give that correction dose plus the booster dose, the ketones, via syringe until you have time to troubleshoot your pump. So he checks his blood sugar is 456. He's got large ketones. So he gives himself a correction dose for the 456 plus a 50% booster, and he does them together via syringe. He then changes his infusion set, puts fresh insulin in his reservoir, changes everything out, checks his battery. And then I often will recommend that you do a temporary basal increase by about 25% for the first 3 or 4 hours, and that will help catch up as well. Encourage fluids, and then keep an eye on the blood sugar and ketones. All right, so we're nearing the end. Last slide. So quick review of the 6, and then I added a 7th sick day rule. 1, never omit your basal insulin. 2, prevent dehydration. Dehydration alone will increase ketones. It's another stress for the body. So work hard to prevent dehydration. Frequent monitoring of sugar and ketones, CGMs, are really helpful in this scenario. Remember the concept of a booster dose, in that if you have ketones, you need more insulin to do the same job. You want to treat any underlying triggers to the illness or any additional stresses. Number 6, vomiting is from diabetic ketoacidosis until proven otherwise. And then lastly, and most importantly, call for help and guidance. I know your diabetes teams will want to help and guide you through your next illness. And I think that's it. This is a very pathetic flower trying to peek out of the snow here in Cleveland.
Well, thank you very much. We have a couple of questions, so let me see if I can assign these to you and if you can see them. So here's the first. Do you see the question, Jamie?
I see the bottom of it.
All right, so this is, in your experience, do patients develop nausea from Minidose, especially if they were already nauseous and vomiting?
That's a great question, and I should have said that. No. If the low dose is a dose that's sufficient to raise the blood sugar by 40 to 60 points and does not worsen nausea. So they should not have more nausea from the glucagon. Where you're right, or the person who's asking the question, what they're alluding to is that the standard dose glucagon, high dose glucagon for severe hypoglycemia causes nausea. And in about 20 to 25%, people often will throw up after receiving glucagon. Now, some of the other, so like intranasal glucagon, for example, is associated with a little bit less nausea and vomiting when you have to use it for a severe hypo, but Minidose does not cause nausea. You may already be nauseous, but it shouldn't make it worse.
Another question from Carlos, a pediatric endocrinologist in Mexico City. What is your opinion about type 1 patients that need surgery and use CGM, flash glucose monitoring, or an insulin pump?
You mean during the surgery?
Yeah.
So it depends on the surgery, and most importantly, depends on the length of the surgery and how sort of stressful I think the surgery is going to be for the person. I should have mentioned earlier that one of the other hats that I wear is I'm a member of the International Society of Pediatric and Adolescent Diabetes, and we have actually a set of guidelines that we publish every 4 years. The last set was published in 2018, and we have a whole chapter on the perioperative management of insulin-dependent diabetes, and you can get the guideline chapters for free. You don't need to be an ISPED member. On the ISPED website, it's isped.org, www.isped.org. So there's a whole chapter on this, but what we recommend is if it's a long surgery that we take them off their pump and put them on an insulin drip during the surgery. And the cutoff for that, it depends on your experience and your center's experience with type 1. I use a cutoff of 4 to 6 hours. So if the surgery is going to be a long surgery, I just had a young patient of mine have a very complex surgery, and it was estimated to be it was going to be 6 hours. So I took her off her pump and put her on an insulin drip so that I could titrate it during the surgery, because she got very hypoglycemic from the stress and the surgery, and I was able to adjust to it with an insulin drip more quickly than I would have if she were on her pump. But for short procedures, outpatient surgeries, or even inpatient surgeries that are shorter and less complicated, I keep them on the pump. And depending on the anesthesiologist, most I've had be willing to allow the CGM to go into the operating theater, operating room with the patient, and the anesthesiologists have actually loved having access to the CGM during the case. It depends on if the case is going to require certain types of imaging or certain types of electrical currents, then the CGM can't be worn. But in most cases, yes, I try to keep it on.
So we have a question from Rebecca. Is there anything that can be done to stop a hospital that wants to take away your pump, and I would also assume, or your CGM?
I'm just thinking about my own experience at my hospital, and that we have an inpatient pump policy. So we have a many multiple page document about the policy of insulin pumps, and now I actually just submitted a policy on CGMs to our hospital. I don't know, the committees that look at policies. Because I would like my patients to be able to use their personal CGMs while they're in the hospital. So the rule, it depends on the hospital, depends on their experience with it. But if they feel that you are not able to independently manage your pump during the hospitalization, they're likely to ask you to go back to injections, in that they don't have the knowledge or the comfort level to do it safely, and they feel safer using injections. So if you were so sick that you couldn't, you were lethargic and not feeling well, and you weren't with it, and you can't operate your own pump, and you didn't have a family member with you that could operate it, they would likely take you off your pump. And so if that's the scenario, there's probably not much you could do to force them to allow you to keep it, because in a lot of scenarios they don't know how to manage it. They don't know how to program it. They may not even know how to give a bowl pump. But again, it depends on the scenario, depends on their experience and knowledge.
So then we have two final, one's a comment and one's a question. Comment that we have to be careful now with difficulty breathing because it could be secondary to DKA and also COVID-19.
Yeah.
And then there was a comment that there was an article about patients with COVID were advised to be prepared to take care of their own diabetes if they were hospitalized. So do you have any thoughts on that, and what would happen if someone were on a ventilator, for example?
Yeah, so the first comment is a good one. And then I just finished a week of being on call for the hospital. And like I said in my opening remarks, we all have COVID on the mind, and that's what we're worried about. That's what we're thinking about. And I had, in my last week, I had 2 newly diagnosed patients, 2 kids diagnosed with type 1 for the first time, and they had a delay in seeking medical care because they were afraid of going to the emergency room because they didn't want to be exposed to COVID. And so in both the cases, the parents knew what was wrong. They didn't know about diabetes. They didn't know the symptoms, but they knew something wasn't right. And so by the time they came to the emergency room, in both of these kids, they were both in pretty severe diabetic ketoacidosis. And when they came in, they were flagged as suspected COVID by the emergency room because they were breathing hard. And it's called Kussmaul respirations, which is the breathing pattern that someone does when they have when they're in ketoacidosis. And it wasn't until they got the labs back and realized that no, this wasn't breathing difficulty from COVID, this was breathing difficulty from severe DKA, and then the COVID was taken from their chart. So if you have to put the whole scenario together. So if you're having difficulty breathing, but you have a high blood sugar and you have ketones and you're nauseous, then that's going to be much more likely DKA than COVID. And also typically COVID infection is going to come with a cough, and it's going to precede the difficulty breathing. And DKA doesn't cause a cough. It's more just frequent shallow respirations. And then the second was, I read that same article that the person who asked the question did about if you're admitted, being prepared to manage your own diabetes. And I think that's hitting on what we already talked about, that lot of hospitals, and again, incredibly well-intentioned, hardworking people are just not very familiar with type 1 diabetes management and sick day management and operation of pumps and sensors. And now we have, amazing systems with low glucose suspend and control IQ. And so I think that's what they're alluding to, that they need to, they are not going to understand your diabetes management. The other scenario that I read about is that if trying to minimize exposures, and if someone's infected with COVID, that the staff may not be wanting to come in frequently to trigger or to look at your pump. So I was actually on a call with my hospital, and I do a monthly meeting called the Glycemic Control Committee, where I work with endocrinologists as well who are taking care of patients with COVID infection and type 1. And they went and bought a bunch of CGMs, the hospital did, so that they could put all of the patients with type 1 or insulin dependent type 2 on a CGM so that they can monitor them remotely outside of the room to decrease the number of times they were in. But I think you do have to self-advocate, but if you're not well enough to take care of your diabetes, I'm surely hopeful that someone would step in and help with that management. And people are using pretty innovative ways to do that in the setting of COVID. I mean, we're fortunate in my very large pediatric hospital that I work at that we have not had somebody in the pediatric side of the hospital positive for COVID. So it's still pediatric patients are very, very rarely hospitalized with COVID.
Very good. Well, it's 4:15. That concludes our webinar, our Screenside Chat on sick day. Thank you very much, Dr. Wood. We appreciate your time.
My pleasure, and thank you for having me.
Yeah, this recording will be online tomorrow at cwd.is Screenside. That's cwd.is/Screenside. And then you'll have an opportunity to download the PDF. And we'll make sure to put the link to the ISPAD sick day guidelines that you had referenced in the write-up.
Yeah, there's a set of guidelines for sick day that I'm one of the authors on, and then there's a chapter just on surgery.
Very good. Thank you all very much for joining us. Until 2 weeks from now when we return, have a good day and stay healthy. Bye-bye.